I just want to thank the Life Sports Science Institute and the Professional Baseball Chiropractic Society for having me, and then particularly Dr. Mark Kovacs for inviting me. I think this is a fantastic meeting. This is actually pretty gratifying following PJ's talk. I grew up about 20 miles from Wrigley Field, so to follow someone who's with the Cubs is actually a pretty cool thing for me. I have no disclosures related to this talk. And really, the learning objectives there are about 5 of them. The first is, let's understand actually the epidemiology of and risk factors for a UCL injury in the throwing athlete. The second is a very brief review of the anatomy and just why the injuries do happen. Some misconceptions and realities really revolving around UCL reconstruction. Now, full disclosure, I'm not a surgeon, but I work closely with some surgeons, and there's a lot of things that parents will ask, or their sons, sometimes their daughters, will say in clinic that just really don't make sense. I want to address them. Understands the principles for, I don't want to say UCL prevention, but to potentially decrease the risk of a UCL injury, I think is probably a better way to say it. And then, what about all this pitch restrictions? I think everyone's aware that these things about pitch counts now seem to be really hot in the news, particularly at the Little League and at the high school level. So we've actually done some research at UF. We just completed a study, the first one's been done on this that we're aware of. So I'll share with you some of the initial results. So when does the injury cycle start? And what I mean by that is, I don't mean in April or in January or June. What I mean is, does it happen when your son or daughter starts playing Little League at 6? What about when you get into that middle school level, right before puberty is really starting to kick in? Or maybe it's high school. You're starting to throw, if you're good, and in those 70s, maybe low 80 miles per hour, maybe higher if you're a prospect. Maybe college. I had to get in a picture of one of the Emory baseball pitchers. Or maybe it's pro. I actually put up this picture of Kerry Wood in particular because I remember when I was a senior here at Emory in 1998, one of my best friends, who actually lives 20 miles from here, and I were watching on TV May 6, 1998, strike out his 20th batter. And what happened next year? He tore his UCL. It didn't happen from his 1 year in the majors or his 2 years in the minors. It happened because something happened when he was in high school or younger. It happened during youth, and it happened in his pre-high school years. And this happens to everybody. I don't care who you are, baseball, softball, javelin, any overhead athlete with respect to the UCL, that's when the cycle begins. We just don't notice it until you see a story in ESPN or Fox Sports or CBS Sports that so-and-so tore their UCL and they're out for 12 to 15 months. But the cycle starts much earlier. So, what exactly is the UCL? What is the Tommy John ligament? So very briefly, why do we care? We care because the UCL, the real purpose of it, the reason it was made, designed, is to prevent and resist valgus loads, but it also prevents stability. It prevents stability when you're talking about throwing, overhead throwing in particular, during the deceleration phase of throwing or pitching. But it also generates a varus counter torque. So for every push and pull, agonist-antagonistic force, just like PJ just talked about with hamstrings, you're talking about a valgus force to the medial elbow and a varus counterbalance force to the radiocapitellar joint or the lateral elbow. If the UCL goes, you can't throw, period. So very briefly, the UCL actually has 3 bands. The anterior band, the posterior band, and there's that oblique band, and really the oblique is just the connector between the two. For the most part, when you hear about someone rupturing their UCL or has a high-grade tear of their UCL, it's that anterior band. The anterior band is the chief restraint to valgus stress, typically up to about 90 degrees of flexion. When you start to go into more than 90 degrees of flexion, or if you want to say between 60 degrees and full flexion, that's when your posterior band starts to take over. Okay, so that's important just from an anatomical standpoint of what is being active, what is absorbing the most amount of force or stress when you're making an overhead throw. So very, very briefly, biomechanics of the elbow. And by all means, I'm not a biomechanist, but I read a lot of the papers by Glenn Fleissig out of ASMI in Birmingham, a lot of other biomechanists. And it's important to understand there's a lot of torque on the medial or inside part of the elbow. Anywhere from 65 to 80 Newton meters, and I would guess this number is higher with the number of major league pitchers and minor league pitchers, for that matter, that are topping 97, 98 miles an hour. I'd be very curious what Aroldis Chapman's level is when he's throwing 105. So, but we also know that angular velocity at the professional level is as much as 5,000 degrees per second in the elbow in a high-level pitcher. This typically occurs greatest during the late cocking and early acceleration phases of pitching. And this is actually pretty important, especially for the students here, understanding why does this matter? Like, why do you care about this? Well, there's three major forces and stressors placed on the elbow when you throw. It's not just all the inside part of the elbow. There's a tensile stress, and that will affect the medial part of the elbow, which includes the UCL and also something else that doesn't get as much press, but it's the flexor and pronator. The second part, remember, if there's an agonist, there's an antagonistic force. So you have a tensile stress, then you have your compressive force. So if you think about it, if everyone takes their elbow and creates a valgus stress on the medial side, that means the lateral side is compressed. So that affects the counter or the opposite side of the elbow's forces. But lastly, there is a shearing force. When you hear about a stress fracture in the back of the elbow, a tricep strain, that's when you're hearing about a shearing stress in the posterior compartment of the elbow. So the two stressors and the force, the three of these combined, makes things very simple if you kind of think of it like that. So again, we're talking about all this stuff, and is this stuff in the lab? Is this stuff on the field? Is this stuff that's computer-based modeling? Well, if you look at it, and a lot of this work comes from Glenn Fleissig, is the UCL, based on a cadaver study, provides more than 50% of the stability to the medial elbow when throwing. So in one particular study, it said 33 Newton meters out of 64. Okay, interesting. If you look at some other studies, depending on how fast you throw, how old the pitcher is, it can reach above 80 Newton meters. As I said again, great. But why is this important from a clinical standpoint? Well, number one, if you look at this, the mean torque on a pitch-to-pitch basis is greater than the torque to failure, I mean what it would take for the UCL to rupture, by 2.5 times. That's sort of interesting, that the UCL basically should rupture every time you throw a ball more than about 80 or 85 miles per hour, but that doesn't happen. So I pose the question, maybe very small changes in fastball velocity and pitch composition are potentially significant when considering velocity programs. So strength and stability programs, as I'm preaching to the crowd here, are very important. So when you hear about, and I think someone mentioned this morning, someone would go from an 85 mile an hour fastball to an 88 mile an hour fastball, is that really that much of a big deal on the elbow and for that matter in other parts of the body? I would say yes, it is. So think about that, and we'll come back to it. I also want to mention the flexor and pronator mass. Now, it's important to understand that if the UCL is failing, the next structure to pick up the load medially is the flexor and pronator complex. I'm not sure how closely you all follow Major League Baseball, but a couple years ago, before Steven Strasburg started to have his UCL injury, you started hearing the news about, oh, he's got a flexor strain, he's got a pronator strain. Anyone who takes care of these athletes knows when you start hearing that, something else is going on with the UCL. You do not want to have a flexor pronator strain injury because you're basically taking away the secondary muscle stabilizer to the UCL. So what happens if we strengthen that? Based on computer modeling, based on some theories, if we increase the muscle tendon force output with strength or activation, theoretically it should decrease the load on the UCL. That means potentially decreasing UCL injury. Or conversely, if you don't do that, you increase your risk of UCL injury. So why do we get injured? So I've started reading more and more papers by Tim Gabbage over in Australia, and this applies not just to baseball, not just to throwers. This applies to anybody who does anything athletic. So if there's any slide you're going to remember, it's probably this slide. It's why do we get injured? There's intrinsic risk factors, there's extrinsic risk factors, and then there's the inciting event, there's the stimulus. So let's think about this from the baseball pitcher standpoint, since that's really the purpose of the talk. We have age. Maybe we're taking care of a skeletally immature pitcher, 14-year-old. Maybe we have a major league pitcher, so that will change. Flexibility, this was just talked about in the previous talk. Previous injury. Maybe there's a history of elbow soreness that hasn't been diagnosed before. or there's never been an MRI or an ultrasound to know, is there been a sprain or a partial tear in the past? What about somatotype? Did genetics come into play? Are you 6'5"? Are you Aaron Judge or are you Jose Altuve? I mean, there's a difference there. You can't change some of that stuff. You can be aware of it, but you can't change some of it. The next part is the exposure. How much are you pitching? Are you used to throwing a 40-pitch bullpen and now you're asked to go throw a 110-pitch start to save the team? That's a risk factor. Then the assigned event is the actual pitching itself. So using this very simply from the perspective of taking care of a baseball or overhead pitcher, you have all these things I just added in. And we can work on these things not to prevent injury, but to mitigate it and decrease the risk of it. So every January in Florida, March or April probably up north, this seems to happen. This is not true, but anyone who has an elbow injury who's a pitcher does not need Tommy John surgery. And I've actually used this slide before, and I have folks come up to me afterwards from parents, lay folks, up to professionals, and they say, I hear the same thing. So it's really important we get the message out about who needs to have what done based on what amount of injury has been sustained. The problem is we have data on this. UCL reconstruction in professional pitchers from 1974, that was Tommy John himself, through 2014, everyone can see it's a mountain. It's gone way up starting in the mid-1990s. Now the theory is, what happened in the mid-1990s? Well, it wasn't actually the mid-1990s. It was the early 90s to late 80s. And guess what happened then? Travel ball leagues, showcases, it became big money. Well, at some point, the elbow is going to fail if you keep throwing in pain, you keep pitching in pain. But that's just professional pitchers, so we're all good, right? That doesn't happen to about 98% of the population. Problem is, you go to ASMI and Dr. Andrews' team. Well, look what happened from the mid-90s to about 2011. This is pre-high school level. The amount of UCL reconstructions in the little folks has gone up over 6-fold. Well, at least it is in high school and college, right? Nope. If you look at Dr. Romeo and Dr. Erickson, their team at Rush, who's doing a significant amount of this also, they looked over a decade that ended in July of 14, 6-fold increase in their amount of UCL reconstructions also. So we now have kids from about 9 or 10 years old up until the late 30s. This affects every single person who's playing baseball. Why? Well, this was actually put out in some of the baseball blogs going, maybe there's been some hope, and this was also a way of me sneaking at least one Star Wars little cartoon there. But maybe there is a little hope. Look, the amount of UCL reconstructions has decreased in 1 year. This is crap. Because as anyone who studied any epidemiology knows, you can't look at 30 years or 20 years worth of data and say, oh, this 1 year means it's all better. That also means if you've one horrible year, you can't say that something is happening and we need to turn it all around. We have to look at this over a 5 and 10-year period. It took 30 years to get here. It's not going to be better in 2 years. It's nice to see this, but just be aware when we start seeing this every spring that maybe things are going worse or maybe things are getting better. So what is the epidemiology? One study by Stan Conti, who's the former Dodgers head athletic trainer in 2015, 15% of all minor leaguers and a quarter of all major leaguers at some point have had UCL reconstruction. That doesn't mean they had it when they were pro pitchers, but they had at some point. Think about that. Can you say that a quarter of all NFL quarterbacks have had ACL reconstruction? No. Can you say that a quarter of all professional soccer players have broken their ankle? No. This is tremendously high. This actually just came out in the last month. This is a really nice epidemiological study looking at epidemiology of shoulder and elbow injuries in high school level baseball players in the last decade or so. And I took out the shoulder data just to focus on elbow for right now. And there's about a rate of 1 elbow injury per 10,000 athlete exposures, where an athlete exposure is diagnosed as 1 practice or game. Okay, that's not too bad. But interestingly, though not unexpected, the injury rates were increased in competitions versus practices. Why might that be? Maybe the intensity is more. Maybe you actually are throwing a lot more in games than you actually prepared for in practice. What about most injuries? The type. The types were sustained mainly by pitchers, which you would expect. Second most common, who would guess what position after that? Catcher. Yeah, catcher's number 2 because they have the most amount of throws and the most amount of stress in their elbow. But interestingly, it's the chronic and overuse injuries. It's very rare that someone's going to go throw a ball, never hurt their elbow before, and tear their UCL. It's a chronically acute injury. It's something that's been happening for 10 years until finally the UCL just says enough is enough and ruptures. For pitchers, most common ligament sprains, which would make sense. And for pitchers, a significant amount, proportion of elbow injuries actually result in medical disqualification as opposed to maybe you just have a little tendinitis and you're just going to miss a day or two. You're actually out for a certain amount of time. A very nice epidemiological study performed by the head team physician for the Yankees, Dr. Ahmad, looked at the entire state of New York using a medical billing system from 2002 to 2011. The volume of UCL reconstruction increased 200% and the rate tripled. Okay? Well, our team at University of Florida actually looked at something because, like I talked about before, not everyone needs Tommy John surgery, and it doesn't have to just be in baseball, does it? So we took a look. We looked at retrospectively from the start of the century, is how we did it, up until the middle of 2016. So about 15 and a half years worth of data. And we looked at frequency, severity of UCL injury, was it a complete rupture, a partial tear, a sprain, and injury management, who had surgery, who didn't, for everyone from 11 to 22. There were 83 non-surgical injuries compared to 53 surgical. Non-surgical cases increased ninefold in the second half of the study versus the first half. So what is that telling us? I think we're all much better at being aware of these injuries now, so there's that potential bias there. But I think it's also that we're aware of these injuries to diagnose and prevent them from getting worse. As you can tell, baseball dominated the amount of injuries, about 100 out of the 170 or so. Number 2, 3, and 4, softball, American football, and javelin. Interestingly, if you look at the odds ratio, if you were to sustain a UCL injury, the most likely sport where you're going to need UCL reconstruction is not baseball. It's javelin. The reason is because the length of the spear and the stress it puts on the elbow is actually greater than in baseball for anyone who helps take care of track and field athletes. The question that we're dealing with those is, what do we do with the middle group? If you rupture a UCL, you need to have it reconstructed. If you have a small sprain, a very minor sprain, we can treat that non-operatively. It's the partial tears. What we found was nearly 50-50 had surgery, 50-50 did not have surgery. And that's really something we can talk about at a further talk, but the question is, why are we having all these partial tears? One thing we found out is the younger you are, the less severe the injury is because you can't throw as hard. So you go from a sprain when you're 12 to a partial tear when you're 15 to, guess what, when you're 18 you can throw 85 to 88. You rupture it because you already have a partial tear. So again, that goes back to my very first slide. We have to prevent this before it even starts. So, why are there so many UCL injuries? Well, I think overuse is a big one. I think that is really not even controversial at this point. The second is prior injury. If you've had a prior injury and you didn't allow it to heal, you didn't rehab it fully, and you're pitching through pain, you're at risk for developing more injury or more significant injury in the future. Connect chain deficits. Actually, Dr. Manimal already went through most of this, but if there's any literature you're ever interested in, I'll read anything by Ben Kibler. If his name is on it, I'm going to read it on the Connect chain. There's controversy on weighted ball and velocity programs. I know Dr. Kovacs spoke on this last year. I'm not ready to completely say it is a negative, but the research is starting to trend in that direction, but it's still in a very short amount of time, but that's something everyone should be aware of at this point. Sports specialization, particularly before you enter high school, has been shown in every sport to be a risk factor for injury and burnout. And then poor biomechanics. So let's talk about this. Feel a need for speed. If you look at some data, has shown that the average Major League Baseball fastball in pitchers in less than the most recent decade has increased nearly 3 miles per hour. That's a 2.5% increase in 9 years. So remember one of the earlier slides I talked about, even a small change? That small change puts a little bit more torque on the elbow. Times how many pitches do you throw per day, per season, if you're a college or pro pitcher, per career. That does make a big difference. And as we've seen before, the harder you throw, there's an increased risk of having a Tommy John reconstruction or UCL reconstruction. Well, there is a little bit of controversy on this. If you look at one particular study, this is from Dr. Meister's team out of Dallas, they actually found when they were looking in a motion analysis lab that there was not an association between ball velocity and elbow valgus. They said it was improper pitching mechanics. So he's suggesting the biomechanics is maybe more of the chicken versus the egg. However, if you look at one of the newest studies out, which is actually very interesting by Dr. Fleisig's team, they look at weighted ball training. They had basically high school and college pitchers throw different weighted balls. A typical baseball is going to be about 5 ounces. So they had 4, 5, 6, and 7 ounce balls. They had pitchers throw in different situations. And they looked at the kinematics and kinetics, so with the motion and force versus just the motion. What they found is that the kinematics and kinetics were similar with underweight and with average baseballs, but with the overweight baseballs, everything actually decreased. And you don't really have to memorize this or even try to read this, but the point of this is that everything with a heavier ball, the stress went down. That makes sense, right? You can't throw something as hard if something is heavier. The problem is this, and this is my question. So training doesn't increase stress, but doesn't throwing harder increase stress in the UCL? And the purpose of weighted ball training is to do what? When you're done with that train is to throw harder, which puts more stress in the UCL. So if you've increased stress plus overuse plus poor biomechanics, which is typically every single high school pitcher and every single Little League pitcher that we have ever met, isn't that going to result in wear and tear? So yes, a weighted ball program may be successful allowing a pitcher to throw harder, but then down the line, due to various factors, including ones I'm suggesting up here, it can lead to wear and tear of the UCL as well as other injuries. This is another particular study that's talking about and actually looks at the elbow varus counter torque. So if you look at youth up through at the collegiate to pro level, looking at miles per hour going from 60-ish miles per hour up until the upper 80s, you can see everything goes up the harder you throw. And as I talked about, we really need more research on volume, on ages too. If you're doing a weighted ball program, what if the growth plates are open? What if the growth plates are closed? A 14-year-old versus a 24-year-old, completely different person. Anatomically, as a person, puberty, muscle, flexibility, all that is different. And none of these studies have really been thoroughly vetted yet, and there's no long-term studies yet. So again, how do we protect the UCL beyond saying don't throw in pain and make sure biomechanics are good? Well, one thing we've talked about is increasing the muscle tendon force output, increasing certain muscles that can offload the UCL, the flexor pronators as an example. So not every major leaguer has that type of form, but you sort of get my point. So again, what can we do? What can we do to mitigate and decrease the risk of these UCL injuries? We go back to the simple slide that we talked about before about intrinsic, extrinsic, and then the inciting factor. So, risk factors, overuse throwing, we've known about these for a while. You have basically 2 major categories. You have overuse and you have biomechanics. Within overuse, you have a couple different subsets. You have simply fatigue, and there are a tremendous amount of studies out. I put a couple up just to list. There is not following the guidelines by Major League Baseball and USA Baseball. It's called Major League Baseball Pitch Smart. For those of you who aren't aware, I'm happy to give you the website later if you're not aware of this. There's a theory that pitching in a warm climate allows you to throw all year round. So there's been at least 2 studies out, one by our team and one by the team in Chicago, that has looked at this, showing that there's an increased rate of UCL reconstruction in folks who have either grown up and or pitched in high school or collegiate ball in a warm weather climate as opposed to a cold weather climate. Sports specialization, which I talked about already. And there's the biomechanics, which I'm not going into a lot of detail about, and I think it was mentioned briefly by Dr. Manville before this talk. Range of motion, glenohumeral internal rotation deficit, and really what's come about the real last couple of years, and Kevin Wilkes' article in 2014 talks about it, total arc of motion. If there's more than a 5-degree difference in your total arc of motion between the dominant shoulder and the non-dominant, it actually has shown risk up to about 2.5 times of having an elbow injury in the dominant elbow. So total arc of motion is something to be paying attention to. This is probably one of my favorite studies. This was done out of ASMI. This was a fellow at the time, and what they looked at, their team there is adolescent pitchers. Very simple, right? If they threw more than an average of 80 pitches in a game versus those that threw less than 80 pitches in a game, there's a 4 times risk of having surgery. If you pitch competitively more than 8 months per year, which is possible in the South, there is a 5 times likelihood of surgery. But here's the kicker. This is the stat that I show all the time. If you pitch regularly with a fatigued arm, remember at the adolescent level, there is a 36 times as likelihood to have an injury and potentially need for surgery. How many of us either know of, were that athlete, or have treated patients that said, my elbow's hurt for a couple years before, I just rested for 2 weeks. Or I took ibuprofen for 3 straight weeks. Or my mom or dad said, just put some ice on it and rested for 1 day. This is what's happening at the adolescent high school level, which is why you have that spike in UCLs in the professional level and collegiate level a couple years later. So what are some of the myths and realities about UCL reconstruction? Well, UCL reconstruction is a very good surgery. Depending on which study you look at, 80 to 94% say you can return to the same level of competition or above, and actually they're continuing to get a little bit better if you look at some of the newer studies as well. So it's a very good surgery, but 100% do not return to the same level. You also have to understand, if you have UCL reconstruction, let's say you're 15 or 16, you're a sophomore or junior in high school, your high school career for the most part is over. A lot of these studies are looking at college or pro folks who can stay and go to rehab 24 hours a day, 7 days a week, and it's their job. It's very different at the high school level. The second is, you can return from UCL reconstruction in about a year. No, that's not true. If you're a professional level, you might be able to, but if you're at the high school level and younger, what I typically say is you're looking at 15 to 18 months. The reason is, just like I talked about, you have to go to school. You don't have all the advantages that a pro athlete or a high-level Division I athlete has. And if you look at all the studies, it range from 12 months, in some cases up to 55 months, so I think a couple of those are a little bit of an outlier. I typically say 15 to 18 months and let's see what happens. But understand that's a big, big risk unless you absolutely need to have the surgery. Third is this is a one-time procedure. Now remember, go back to that very first slide of all the epidemiology of the surgeries, and we saw that spike in the mid-1990s. Everyone remember that? So what has been happening is you're having surgery when you're earlier and earlier or younger. These reconstructions, the grafts, at some point are going to fail. Now it's one thing if you're Tommy John himself and had it done in your 30s, you're pretty much retired unless you're Nolan Ryan or Roger Clemens, you're retired by the time you're 40, right? Well, unfortunately, because you're having UCL reconstructions earlier and earlier in your lifetime, there's an increased risk of failure 6, 7, 8 years later. The problem is, if you're 18 and having this, you have run that risk of failure when you're 26, when maybe you're just about the major league level. So because of that, 15% of professional pitchers have required at least one revision surgery before their careers ended. And there was a little expose that ESPN did in 2014 that showed more than a third of all MLB pitchers undergoing UCL reconstruction required a revision surgery. And that is most likely due to the fact that a lot of these guys are having UCL reconstruction earlier in their lifetimes than they used to be having done. Another thing is, and as a non-operative physician, if we take a look at this, this is from Dr. Romeo's team again, is more than 50% of all those UCL injuries that they did surgery on between 2004 and 2014, 51% were non-traumatic. They were acute, they were chronic, non-acute injuries. This is where we all can make a huge difference. So how do we actually prevent it? And again, we're not going to prevent it, but how we mitigate it, but how we decrease it. Well, number one, it's really not rocket science. I mean, this is coming directly from Dr. Andrews himself. Some elbow injuries simply can be prevented with safety rules, recommendations such as following pitch counts and pitch guidelines, education, and common sense. Common sense being if your elbow hurts and you're an overhead pitcher, you probably should not be throwing until you figure out why your elbow is hurting. So some very basic prevention principles. Following rest guidelines, I put the website up for the Major League Baseball Pitch Smart, and those rest guidelines are really based upon the amount of pitches one have pitched in a start and the amount of days of rest based on the amount of pitches you've pitched. Preseason throwing programs, which I'll come back to in a moment. In-season conditioning, range of motion assessments. Now, if you are a pitcher at the professional level, high-level D1, Major League, these are being done all the time. But how often do you think a freshman in high school is getting a full range of motion assessment beyond their shoulder? They're probably not being done. So these are things that we can do to help prevent injury before they even happen. So, Doc, what about a throwing program? So let's take this back a moment. This is based upon the fact that I grew up in Chicago and I practice in Florida. We're in Atlanta right now. This is a warm weather area. So up north, high school preseason is probably about February or March or so. And their high school season is usually around April, maybe March is when games start, go until around Memorial Day, maybe beginning of June. Sounds about right. In the South, preseason, high school preseason baseball's already started for me. But for most folks, that's not true. But in the South, you have to be aware of when the preseason is. In their season, we start games the second week of February. You get into the state playoffs, it's the first week of May. If you don't make it out of the first round of the playoffs, you are done the first week of before Mother's Day. For me, when I was growing up, I wasn't even halfway through my high school season then. Travel ball. Travel ball for folks who live up north, and again, this is the high school, junior high level. We're talking maybe Memorial Day to Labor Day. That's pretty typical. In the South, May until when's high school season start, right? I have kids coming in November and December. I've had a kid last week because he needs to get ready for his Thanksgiving showcase. That's something, A, I did not grow up with, and B, that's another contributor to these injuries. Prime time training, in my opinion, for a kid that's living up north, October to January. That's about 3-4 months. You can work on your connect chain, stop throwing, do some other things to get ready. In the South, what's an off season? I've literally had someone say that to me. I literally have no idea what you are talking about. That's the challenge, depending on where you practice, California, Louisiana, Texas, Florida, as opposed to Massachusetts, Illinois, Minnesota. And it's that balancing act. In the off season, you need to build yourself up. And I think Dr. Kovacs said it this morning, this is when you need to push yourself. Not necessarily throwing, but you really need to push yourself in the off season so that we balance it in the in season. And I think we're doing a much better job in season as a whole around the country with these baseball injuries. It's the off season, because there isn't an off season a lot of times. Is anybody not aware of this new phenomenon called acute to chronic workload? Is anyone not aware of that? I just want to briefly highlight this. So this again comes from Tim Gabb in Australia. He and his team have come up with this. An acute workload essentially is an athlete's fatigue level. It looks at whatever you're doing, what do you do in a week? And a chronic workload, you can think about, is kind of averaged over about a month or 4 weeks. That's your state of fitness. So we'll use running as an example. If you normally run 3 miles 3 times a day for 4 weeks, that's your chronic workload. And if you go for a run for 3 miles today, that's your acute workload. Well, what happens if you normally run 3 miles 3 times a week, that's 9 miles, and you're like, you know what, I'm feeling really good, I'm going to go run the marathon. 26 compared to 9, you just increase your workload 2.5 times. So that's what they're getting at, because this can help build trends in predicting injury. Not preventing, but predicting injury. So this is another great slide, but I'm going to try to explain it in the context of a baseball pitcher. So I'm not sure how well the color comes out here, but right in the middle you have the sweet spot or the decreased injury risk, and that's where your acute to chronic workload ratio, somewhere around 0.9 to 1.2. Whatever you do in a month is about what you do in a week. And if you start to increase your acute workload, so let's take this back to a pitcher. If you normally throw 100 pitches in a game, give or take, which is pretty standard now, and this one game, the coach says, we're out of pitchers, everyone's sick, and you throw 150, you've increased that workload to 4/3, or about 33% increase. You run the risk of increasing, or you have an increased risk of injury because of that. So for baseball, you need to find out your preseason bullpens, how many pitches are you throwing? Because I will guarantee you, if anyone here helps take care of a baseball team, and the last bullpen that a pitcher threw was, say, 60 pitches, and they go into a game, their very first start, and say, we're putting on a 60-pitch limit, they're actually throwing more than 60 pitches, and I'll explain why in a second. The second is how many live game pitches in the first few starts. When are the most amount of baseball injuries each year? It's the first month of the season. And when's the second most common? During spring training professionally or during preseason for high school and college. Why is that? Third, how many total pitches were thrown in the first few starts? Because of that, our team actually at UF came up with this question and going, are we actually missing something that is right in front of us? Something that has been there for 100 years that no one is actually counting. So I want to do a little test here. One game, when you're pitching off of a rubber, off of the mound, you have your live game, you have your bullpen, you have your warm-ups, plus you have your other stuff, your long tossing, throwing poles, things like that. Let's say you take your high school team's top 3 starters, and they each get about 10 starts in a 3-month season. Maybe a little more, maybe a little less, but let's say about 10. In travel ball, let's do the same thing. So this is a travel ball team up north. You get 3 months of high school, 3 months of travel ball, and you get to do a start, about 20 starts a year. And again, I'm being very conservative here because this happens a lot more frequently, especially if you're the number 1 or number 2 starter. But for the sake of math, let's just follow this. So you have 20 starts over 6 months. How many pitches do you think they're throwing? So someone guess, how many pitches in a game do you think a high school pitcher typically throws? 65? Okay. 80? Yeah, that's actually very good. That's a perfectly good estimate. Because of that, we studied something that is called basically the pitch count study. We currently have this submitted, and we're hoping to present to a conference next April. But basically, we had 2 theories. One is we're underestimating the volume of pitches off of a rubber by nearly 40%. And the second is no one has any idea how many bullpen pitches someone's actually throwing. Again, this is the high school level. They're not being monitored like high-level SEC, ACC pitchers or professional pitchers or major league pitchers. But again, when does the cycle start? When you're high school and younger. So this is when we need to catch them. So what we did is we counted all pitches thrown off of a mound, and I can't, number one, thank the amount of undergrads who helped me, but sitting in a stands going like this from February through May last year, we saw 34 different high schools and counted nearly 14,000 pitches. And we saw over 115 varsity high school starting sessions. We can't say pitchers because some pitchers may have overlapped, but we saw a lot of pitches. And what we saw is the average amount of bullpen pitches was close to 30 pitches. Warm-ups, which are a product of the amount of innings one is pitching in the game, was somewhere around 20 to 25 pitches. And game pitches was actually great. It was 70 pitches. I was actually really happy with all of the coaches because if you just look at the game, 70 pitches a game, that's perfect for a high school pitcher. And yeah, they go up a little bit closer to the playoff time when you have your number 1 or 2 starters going. Problem is, how many pitches are actually throwing off of a rubber? 120 pitches a game, and that doesn't even go into above the mean. 42% of pitches are not being counted, at least in our particular study. Now, to be very, very blunt, we are not accounting for intensity, stress, muscle fatigue. We are just counting pitches. So we all know some pitchers will throw harder, some will not throw harder in the bullpen and then warm pitches. But just like PJ said before, if you're running to first base and you haven't done it before, you're doing something. You're increasing your workload. You're increasing your workload every time you throw a pitch off the mound to some extent. The other thing that was really interesting is when you look at the variability of bullpen pitches. We had 25% of our pitchers throw less than, I think it was 22 pitches, and we had 25% of our pitchers throw more than 33 pitches. If you actually looked at, we had a bunch of pitchers throw 40 and 50 pitches in the bullpen. We had one pitcher throw 54 pitches in the bullpen, and they only lasted 48 pitches in the game. Something does not seem right about that. So again, you can see just in a nice little pie chart here that more than 40% of the pitches we're not even counting right now. So if we go back to this little simple math test, that there's over 2,400 pitches in a very straightforward 6-month season for someone who lives up north at the high school level. What does that mean? Well, if you look at a really nice study out of the Journal of Athletic Trainer that came out 2 years ago, they used a high-level number of pitches in a season as 400. Think about that. So I think we're starting to see here that we're not actually counting things that are going on, and that's a reason why there might be a lot of earlier in-season injuries, particularly to the UCL as well. So some of these rest guidelines I'm going to kind of blow through because I think we know about this. You shouldn't be pitching 12 months a year. Usually once you get to about 8 months, you need to shut down. Really, there should be limits on pitch counts, adhere to days of rest, avoid multiple teams, and participate in showcases. I had one catcher come in to me last January for a preseason showcase. He hadn't started games yet, and they had 6 games in 3 days, and he had elbow pain. And I just said, really? Dad did not understand why his son was hurting. And I said, you can't play 6 games. He actually caught all 42 innings, so 7 innings a game, 6 games in Friday, Saturday, Sunday. He could understand why his son's elbow was sore, and his son just caught 42 innings. Throwing programs, I'm not going to get into very specifics of throwing programs. What I want to convey is someone needs to do a throwing program. So that means that you need to be building up your arm strength in the off season, so when you get to spring training or you get to your first start, it's not as if you're going onto the mound only after 2 or 3 weeks of throwing. It should be after a 6-week progressive program. This is actually great. So Japan has been putting out a lot of data on interventions for youth-level baseball pitchers. And this one just came out a couple weeks ago on an intervention program to prevent medial elbow injuries. And it's very simple. They took, at ages 8 to 11, basically they took an intervention group and a non-intervention group. And the intervention group just had simple strengthening programs and stretching programs through their entire connect chain. Their flexor pronator, shoulder, thoracic spine, hamstrings. That's it, 1 time a week or more. And what they found was that their intervention group had a 50% decrease in the incidence of elbow injury. This is at 8 to 11. If this gets done all the time, when you get older into high school and in college, this becomes part of your routine. We can start to decrease these injuries. But remember, we've got to come back to the biomechanics. So this is another study, another one of Dr. Fleisig's studies. But what they found was when they look at a 7-year longitudinal study, because remember, a 13-year-old, as we talked about, is very different than a 17-year-old due to puberty, muscle strength, you've grown, your growth plates have closed, lots of factors. What they found is the year-to-year changes for your kinetics and kinematics really start to change right about when you enter high school. Okay, why does that matter? That means if you don't teach good mechanics before you get to high school, which is when you start to get more power and can throw harder, then you're going to be teaching someone to throw with likely overuse with poor mechanics, and there's that wear and tear, and that means your UCL is going to go at some point a couple years down the line. So that's why, again, it goes back to, again, I'm harping on this, my very first slide, we've got to get to these kids when they're youth and that junior high level, because that's when the cycle starts. So again, why are there so many UCL injuries? Overuse? Check. Prior injury? Yep. Connect chain deficits? I think we all agree on that. Weighted ball and velocity programs, I'm not ready to put the check mark there, but I think we're heading that direction. Sports specialization, I think we all agree on that. And then poor biomechanics. It's a multifactorial approach, which I think everyone here understands. So again, I'm preaching to the crowd, but it's when can we get to these pitchers? So if we had some future research that it's needed and were some gaps, solely in my opinion, is it prevention versus treatment we're aimed at? Treatment is a whole different talk, and if we're talking about platelet-rich plasma injections or stimulation of muscles or different surgical techniques, that's a whole different talk. But we need to isolate specific muscle groups, and I think we're doing that from a kinetic chain standpoint, but maybe we need to figure out, again, what we can do to offload the UCL itself. The second is we need more prospective cumulative studies with intervention like that Japanese study. And then what we need to do is combine all these factors into one. We see too many studies with, well, velocity and range of motion, or strength in the gluteal muscle with shoulder range of motion. We have to combine everything because as the human body in the kinetic chain, you can't take what you want to use. You have to combine all the factors together, and that's very difficult to do. So what are the take-home points? Number one, a UCL rupture is not an acute injury. It's a chronically acute injury. Prevention can limit injury. Overuse plus biomechanics plus the kinetic chain analysis really needs to be looked at and looked at thoroughly. And we go back to the slide about intrinsic and extrinsic factors and then the inciting event. So some food for thought. So our in-season monitoring is definitely improving through Major League Baseball Pitch Smart, through grassroots approach, through just, I think, being a little more conservative during the season. I think across the country has gained much better. But I think we really need to improve our off-season throwing to build up our chronic workload. So one thought that I've had, and this would be a tough study to do and tough way to prove it, but if we're going to think outside the box, is do we train hard in the off-season to build up our arm strength? Because if you're throwing a 60-pitch bullpen and you go into your very first start, I just proved to you you're actually throwing 105 pitches, not 60 pitches. So do we actually need to build up our arm strength more in the off-season while continuing to maintain our pitch limits in season. And if we continue to do our job, we're not going to see results right away, but our hope is maybe in 10, 20 years that this will become this.